Team, good morning, good noon, good afternoon. Very, very excited for today's session. It's an all internal affair. And first, would love to start by thanking the people who are making this happen. Beginning with Eugene, who's doing his first solo scribing. So, Eugene, I'll hand the mic to you. Give us an update on how your week has been.
Hello, everyone. So my name is Eugene. I'm from Ghana. My week has been great. I've been going to the clinic. I also do some research as well. So yeah, I had one paper published last week actually, and then I submitted one this week.
Nice.
And then
Wonderful.
yeah, it's been wonderful. Yeah.
Congratulations. That's huge. That's not an easy milestone to achieve. I'm glad you got there. Big kudos to you, and I'm glad you're also getting to see patients and hanging out with us. Thank you for hopping on. A very familiar position is Julia doing teaching points. It seems to be that that's the default on Thursday that I will assume going forward unless I hear otherwise. Julia, what's new?
Oh, it's my favorite default. I don't want to change it. No, someday I will. Pretty nice. I mean, pretty much as you, not really as usual. I mean, a lot of research work and running, but besides, there has been some interviews, job interviews going on yesterday, last week, and it's very exciting at the moment. So I'll see where I end up.
Yeah, fingers crossed. You better share the news with us when you hear. It's exciting times. And speaking of exciting times, I get to co-discuss with Minahil today, who recently matched about a month and a half ago, or yeah, a month and a half ago, is going to be crossing many oceans to complete her internal medicine residency training. Very, very excited to discuss with you, Minahil. It's been a pleasure to get to see you more and more and more involved with the academy and become really somebody who we really admire. And as everybody knows, the way we celebrate that is by putting you in the in the fire seat and discussing a case. Let me hand the mic to you to say hello.
Hello everyone, it's Minahil and I'm co-discussing with the Rabih with the first time. Very excited and a bit nervous too, and looking forward for the Jerome case.
Yes, Jerome. Oh my gosh, if you guys remember the last case Jerome presented, you will be in for a treat today. Jerome, I'll hand the mic to you to say hello.
Hello, everybody. Glad to be back. I'm just finished a stretch of wards and getting ready to transition into some more administrative responsibilities. So I'm really excited to share this case with you all today and just excited to hear the discussion. So looking forward to it.
Very, very glad to have you here. Before we get started, I just want to emphasize that this space is open to everybody. So before you just heard from four different Academy members. I encourage you all to check out on our website uh, what the CP Solvers Academy is and what it entails. And I will just emphasize that all of you are welcome. The core ingredient to be an Academy member, to be like these folks, is just to really want to be the best clinical version of yourself and to demonstrate that by joining us here live, presenting cases. And so, if you are finding yourself in that mold, there's no reason you can't be the next Manahil, Jerome, Eugene, or Julia. And we really, really hope you'll consider that. With that said, I'll hand the mic to you, Jerome, and Manahil, we'll jump in together, okay? Take it away.
No worries, Minahil. I'm looking forward to hear you discuss this case when you're ready for it. All righty. So the chief complaint is a 81-year-old male. He's coming in for 2 weeks of exertional dyspnea and chest discomfort. And just to set the background scene, this was my second rotation. I'm beginning second year, and I was the admitting resident. It was like a late afternoon. I was kind of doing the swing shift kind of thing. So that was the triage call from the ED, and was the chief complaint. So I'll let you all stop there for some discussion.
Oh, awesome. I love the context setting here. Manahil, what thoughts are crossing your mind?
Um, I will start with like chest discomfort. So like we have a 4+2+2 rule. It can be any cardiac issue that will be like cardiac tamponade, Takotsubo, ACS. Then in the pulmonary, it can be due to pneumothorax or pulmonary embolism. It can be due to any pathology in esophagus, like esophageal infection. So that will be my for just discomfort. But now the patient also have a dyspnea that like turn me more towards the heart conditions, and it's of like 2 weeks, so it is like subacute. I would like to know that whether this dyspnea is present at rest or happen with exertion. And further, I will like to know any other associated symptoms if the patient have like sweating, tachycardia, anything else. And yeah, that's from my side. What do you think, Rabih?
Excellent, Minahil. I agree with you. I think that if you look at the chest pain schema, you'll see on the left side are all the life-threatening causes that you just outlined flawlessly. On the right side are all the benign causes that aren't morbid, like chest wall discomfort, GERD, so on and so forth. And I think the reason that you only mentioned the left side is one, those are the most morbid, and two, the presence of associated dyspnea is virtually incompatible with any benign cause. So if you ask yourself, what is the additional value of shortness of breath in a patient who is reporting chest pain? Is it dramatically increases the probability of a sinister underlying diagnosis. Most patients with chest pain do not have shortness of breath and do not have a life-threatening diagnosis. But the presence of shortness of breath really suggests something sinister. Now, it will matter a lot where the chest discomfort is. So, Minahil, if you learn that the patient's chest discomfort is on the right lateral chest wall, patient's having chest pain, shortness of breath, but the chest pain is not in the middle, it's on the side. How does that help you? What might make that?
If it is like right lateral, it will shift my concern from hearts more towards like neuro or maybe
Excellent.
musculoskeletal or ribs.
Excellent. Excellent. Paying attention to where the chest discomfort is can help a lot. If a patient has central chest discomfort, the coronaries and the pericardium become the most important hypotheses. If the chest discomfort lateralizes to one side or both sides, all of a sudden pleural diseases, either infarction or pneumothorax, become more probable. So in addition to understanding more about this patient's HPI, especially paying attention to the time course of 2 weeks, we'll also have to study where this is happening to help us make progress. So Jerome, I'll hand the mic back to you and see what else you have.
Absolutely. Fantastic start as always. Initially, this patient is being brought down to the ED from cardiology clinic. So this is at our subspecialty hospital. This patient was being seen in interventional cards clinic. He has a remote history of a 3-vessel CABG that was done in 2021. He's had some intermittent grafts go down and has been referred to interventional cardiology at our institution for consideration of advanced PCI. So and up there in the clinic in triage, essentially he was febrile to 101 degrees. He was hemodynamically stable, but tachycardic to 110. He told us that, he's had this bout of symptoms before with the chest discomfort and shortness of breath, and he essentially went up on his anti-anginals. So he went up on his ranolazine as well as his IMDR. And he was just very excited because he just felt like one of his grafts were down. So that's why he went to cardiology clinic. And so because of the febrile illness, him being slightly tachycardic and looking a little tired, they brought him down to the ED for further evaluation. And I'll stop there for a brief discussion.
There's the Jerome twist. But what are you thinking now?
Well, now like it's patient have a history of cardiovascular disease, so it's like I am thinking more on acute on chronic condition patient is having. Maybe there is problem in any of his graft, and I will like write about his EKG or any echo. And yeah, these are the thoughts from my side. I will try to look for the EKG, her vitals, and if echo we can get.
Yeah, I think that now that we know this patient has long-standing severe coronary artery disease, and acute on chronic condition is very probable. I'm really curious what happened to you when you heard the patient has a high fever and tachycardia.
Patient have like high fever and tachycardia. It's mostly towards like any infection. It can be like any pericardial effusion or tamponade if patient is having or pneumonia. pericarditis. That will be my differentials. Even
Yeah,
I think in heart
Mhm.
failure that also happens.
Yeah, I think if you, Manal, if you asked yourself in general, what's the most common cause of a fever? Just in general.
Usually infections.
Yeah, exactly. And then what do you think are the most common locations for people to have an infection?
Yeah, it's heart valves in this sense. Or
Sorry, say that again.
bloodstream or heart valves.
What do you think the most common location for an infection is? Most common.
I think bloodstream.
I don't think so. I think bloodstream infections are actually pretty rare. Have you ever had an infection yourself?
No.
You've never had an infection your whole life? Oh my gosh, that's
No, 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 no.
impossible.
Sorry. I mean, I
Wow.
I got
We
confused.
should write you up as a case report, Manahil. Never been infected. Have you ever had an infection yourself?
Yeah.
Yeah, and if you were just to look around your family members, what are the most common infections your family members have had?
So it's most likely upper respiratory tract
Yeah,
infections.
exactly. Is there anything that argues against that this patient has COVID and chronic angina?
Yeah, this can be a possibility.
Yeah, right. Exactly. Exactly. So, I think what's happening in your mind is you're immediately prioritizing the no miss causes. You're like, oh my gosh, this person has really bad heart disease. They now have a fever and tachycardia. I must think of the bad things. But how we think about patients in real life is what's no miss and what's common. So, what do you think are common causes for a fever?
So common causes of fever will be
Yeah.
infection.
Yeah.
Okay, and most likely is upper respiratory tract
Yeah.
infections. And if like you have mentioned like COVID and then after that, like what else?
Yeah. What else do you think are common infections that push people to come to the emergency room? So upper respiratory. What else are common infections?
UTIs.
Yeah,
UTI.
UTI. Excellent. What else?
Mm.
You will see all of these in the first 2 weeks of intern year, promise. So URI, you'll see. UTI. What else do you think you'll see in the first month of intern year?
I
Think
think like
of leg rash. What do you think an infection that causes a leg rash will be?
skin infections like
Yeah,
cellulitis,
exactly.
erysipelas.
Exactly right. Exactly right. So I think it's very it's very hard to say, does this patient have a common infection? And the infection is causing a metabolic stress, and the patient's angina is worse because they have an infection somewhere else. Or is the infection causing this entire new syndrome? And I think, Minahel, that's the difficulty with patients who have chronic conditions, is when they have an acute problem, the question is the acute problem accounting for all of their symptoms? Or is the acute problem also making their chronic condition flare? And so the symptoms that the patient has, a fraction of it is from the disease, and another fraction is it from flare of the underlying condition. So to tell you a personal example, I get really bad migraines. So when I get any URI, I have a fever and a headache. But thankfully, none of my fever and headaches have been meningitis thus far. So far, my fever has been from a URI, and my headaches have been flare of underlying migraine. So I think the question for this patient is, we have fever, tachycardia, chest pain, and shortness of breath to account for 4 things. How many of these things are from a new process? And how many of these things are a flare from his underlying coronary artery disease? And I think we have to be open to both possibilities. He may have a completely new thing that causes all these things, or he may have a completely new thing that causes a fraction of these things, and the remainder of the symptoms are attributable to worsening of his underlying coronary artery disease. So let's see what Jerome has painted for us, but we can try to put these things in those 2 categories.
Yes. So very briefly, whenever I met him in the emergency department, I'll just give you the relevant history. He was pretty tangential, but I was able to pin him down on a few things. He reported that he received the COVID and flu vaccination around the time that he started to feel the exertional chest discomfort and the shortness of breath. And then 3 days after the vaccine, he developed some nausea, some vomiting, some decreased PO intake that sustained for about a week, which coincided with the onset of his symptoms. He also reported that he's been having progressively lethargic. He's not able to do all of his activities of daily living. And I will go ahead and tell you that the review of systems otherwise was unremarkable. And because he came from cardiology clinic, the ED staff got a EKG. They were able to get troponins, and I will say that the EKG is unremarkable. And the troponin levels peaked at 154 and then downtrended to 150. And the cardiology fellow said that he does not need to come and be admitted to the cardiology service particularly, but would benefit from a medicine consult. And I can give you some past medical history unless you want to discuss that briefly, but happy to move forward for the sake of time.
Yeah, well, let's do it. Why don't you give us some more context?
Okay.
Thank you.
Past medical history, as I said, he has a 3-vessel cabbage. He had hypertension, hyperlipidemia. He had type 2 diabetes with his most recent A1C being 8.4%. He also had a pituitary adenoma that was excised in 2013, but the pathology was not available because this happened at an outside hospital. His surgical history, he had a cervical discectomy. He had a some thoracic disc surgery that was pretty nonspecific, but that's all he could tell us. He had and the transfenodal excision of the pituitary adenoma that I already mentioned. Medicines, the ones you would expect: atorvastatin. He was on isosorbide dinitrate, metoprolol, ranolazine, and he was on sitagliptin metformin, as well as an SGLT2. Family history: his mom had multiple myeloma, father had diffuse large B-cell lymphoma, and they both succumbed to those illnesses, unfortunately. Social history: stopped tobacco use about 10 years ago. Previous, probably quarter pack per day smoker. Otherwise, it's unremarkable. I'll stop there.
Oh my gosh, very, very interesting. All right, Minahil, what did this aliquot of information do for your thinking?
So his EKG is unremarkable. That shift
Mhm.
my focus from CVS to other things. As you mentioned, there might be a new thing going on, which is triggering his heart condition.
Mhm.
And like patient is also diabetic. So what was his HbA1c? It was like,
I think around 8.
okay. So it's like around normal. Patient is like, I also want to know if patient is compliant with his drugs or not. And yeah, I am thinking about something else going on in his body other than the cardiac. What do you think, Ravi?
Yeah, I agree with you. I think that as you said, the most important thing to see is his EKG, and the fact that he doesn't have ST elevations or depressions is very, very helpful in this case. And I think the fact that his troponin isn't very, very high is also very helpful. So I think if you were using this context, you would say, I'm not sure what to make of it. It doesn't really change my thinking. This patient has many things going on in their life. Let's understand what we see with our own eyes on physical exam. But I think it's so awesome that Jerome shared with us the EKG before the exam, because the truth is that's what happens in real life. I get handed EKGs on patients with chest pain before I've had the time to see them. So now I think we can confidently say the probability of ACS is not very high yet. We, of course, have to repeat the EKG. So let's study where this patient, what the disease looks like when we lay hands on the patient to help us make progress. All right, Jerome, Mike to you.
Awesome. So we repeated a set of vitals in the emergency department, and he was not febrile anymore. His temperature was 99.5 degrees Celsius. His heart rate was 84 and regular. Blood pressure was 133/85. Respiratory rate of 18, and he was 98% on room air. Generally speaking, he was well appearing, well nourished, well developed, no acute distress. His head and neck exam is pretty much unremarkable. He did have strabismus of his left eye that has been longstanding since childhood. His cardiac exam, he was regular rate and rhythm, no appreciable murmurs, no notable jugular venous distension. Pulmonary exam, he just had diminished breath sounds bilaterally. Otherwise, it was clear auscultation, no appreciable wheezing, normal work of breathing, and conversant in full sentences. His abdomen, he was soft, non-tender, no appreciable organomegaly. His extremity exam, he was warm, well perfused, and no pitting edema. and his neurologic exam was pretty much unremarkable.
Interesting. Interesting. All right, Manaha, what happened now that we've gotten to see the patient? What do you think?
So like I will want to know, like, was patient given any medication before his vitals come back to normal, or
No meds were given.
okay, so like patient is back to his vitals without any medications, examination is normal. I would like to conduct some imaging to know more what's going inside his body, so we can narrow down more differentials. And I will also want to see his CBC, like if there's an infection, that WBCs will help me to get to that infection if there is any. What do you think, Rabih? What would you do?
Yeah, I think it's interesting, Minahil, that we're trying to figure out why this patient has chest pain and trouble breathing. And we have found a couple of things. We found that he has a fever and he has tachycardia. You might think, oh, wait, but his fever and tachycardia went away. Maybe they're inaccurate. But on all of us, the fever curve goes up and down spontaneously. And so I would still invest in the possibility that his fever was real rather than minimize its significance. And I think what's interesting is you're seeing somebody with a fever who has chest pain and discomfort, and yet you're not able to see where that chest pain and discomfort is coming from, nor where the fever is coming from. And so it becomes an interesting exercise to say, okay, could this person have a pleural disease process? It's probably not a pneumothorax or an empyema, but could it be a pleural infarction causing chest pain? Maybe, but the fact that he's not in acute distress is very, very interesting, that he looks comfortable. So I, like you, if I was seeing this patient in real life, I would be very intrigued. He's saying he's having shortness of breath and chest discomfort, and yet when we see him, he looks great. And that might be because his chest pain and shortness of breath are exertional. And so what I would do is I would try to do a basic infectious workup, including a respiratory swab, a chest x-ray, some basic labs. But I think it would be so key to try to walk this patient. Because whenever somebody says, I have a problem here and they look great, maybe they mean they have a problem here when they walk. So I'm really curious to see what the imaging and laboratory footprint of this patient is, but I think we'll gain a lot of insight by seeing what happens when he exerts himself. And if he can go for a jog, I think we would discharge him. But I suspect he would not be able to. And that's why we should take his concern very, very seriously. All right, Jerome, mic to you.
Well, that's exactly what I did because, his symptom reports and what he was actually telling me when what I saw was not congruent. So I did get him up and I walked him. He did use a cane at baseline. So I did, have our physical therapist come get a walker for him. And he desatted to 90%, sometimes 89% just walking around the emergency department. And so I will tell you that. And then so after probably resting about 30 seconds or so, his sats recovered. But I will go to his laboratory work now. So his CBC, his white count was 20, neutrophil predominant on the differential. Hemoglobin was 9.4. His baseline about 6 weeks ago was 10. Platelet count was 632. All right. And then on his metabolic panel, sodium was 131. Let's say his bicarb was 19. Creatinine was 1.3. Blood glucose was 451. His VBG was 7.55 for the pH, PCO2 of 25. His lactate was 2.5. Beta hydroxy was 0.2, which is negative. His ESR was 100, greater than 100. His CRP was 31. His LFTs were totally fine. I'll leave it there.
Jerome, you're such a good case presenter. Oh my gosh. I'm trying to imagine this person, Minahil. this person coming from cardiology clinic, not even coming to the emergency room, and he's just like, "Hi, I have some chest pain," and then you see a fever, a white count of 20, a platelet count of 632,000, an ESR of greater than 100, and a respiratory alkalosis. I mean, I'm so intrigued by the disconnect between the patient and what we are seeing. But I'm really curious. Are you surprised by these labs, and what are you making of them?
I got surprised, like when Jerome mentioned she have DK glucose high, and when mentioned pH, I was thinking that it will be DK, but it was not. So yeah, and like I also like he's getting desaturating on walking. That's also shift my concerns. Like
Yeah.
what's going on his heart? It's like a problem in the heart or like an infection in the lungs, which is decreasing his saturation when he walks.
Mhm.
And also now his WBCs is high, neutrophilic predominant. So I would like to do some blood cultures, CT, chest X-ray to rule out any
Yeah.
Respiratory tract infections. And other than that, I don't know how to relate this respiratory alkalosis with his present condition.
Yeah.
Yeah, that is a big challenging thing for me. What do you think?
Yeah, I think that I, like you, I'm starting my analysis with the neutrophilic leukocytosis. I also think that the thrombocytosis is very helpful because it's relatively unusual for patients to develop thrombocytosis acutely. So I think the fact that this patient has been suffering for 2 weeks is now more apparent. And so I think that we're really trying to figure out a subacute inflammatory disease. And I think whenever that inflammatory disease is neutrophilic in nature, the probability of a viral infection drops significantly. And so I think we're really on the hunt for a bacterial process. And the question is, what kind of bacterial process can present subacutely as evidenced by his report of symptoms and the fact that the thrombocytosis reinforces that? And the most important thing of subacute bacterial infection is often pus under pressure, which means that there is an area of accumulation of purulence, and we have to find that very, very quickly. You might ask yourself, Minahil, do you think that that area of infection is in the lungs itself? What's your take on that? Do you think that he has a very, do you think that the area of infection is pulmonary?
I'm confused here, like this
Yeah.
question. It can be pulmonary and can be some hemolysis going somewhere else.
Yeah, I think that when people have a neutrophilic leukocytosis from a pneumonia, they're often very sick. I have yet to ever be tempted to walk a patient who has a neutrophilic leukocytosis to 20 from a pneumonia. So I think it would be pretty unusual for a pneumonia to be explanatory, but the pulmonary disease that I have seen that causes such a high neutrophilic leukocytosis with relative sparing of the patient's oxygenation and respiratory rate is a lung abscess. So if this patient has a pulmonary abscess, I would not be surprised at all. The other things in the chest that can cause a disproportionate neutrophilic leukocytosis compared to oxygenation is in the pleura and empyema, is in the mediastinum, and is in the pericardium. So I think that no matter what the chest x-ray shows, we should follow it up with the CT scan with contrast. And the contrast here is not to look for a pulmonary embolism, but to look for enhancing pleura or disease in the mediastinum. It also is very important to recognize that if we don't find anything in the chest, many older patients with severe intra-abdominal infections may have minimal to no symptoms. So Minahil, I've seen a case of acalculous cholecystitis, appendicitis with abscess formation, diverticulitis with abscess in a patient who just said, I don't feel good. That's it. So I, like you, I'm very, very worried now about this patient. And I think we need to, the probability that our imaging is going to be high yield is very, very high. So odds are we will see something and the radiologist will call us with something based on the fact that subacute neutrophilia almost always means pus under pressure. So I think we invest in that significantly. Any questions about any of that? Sorry, I didn't hear you. I don't know what, did you?
No, we
Okay,
can
good,
move.
good. Okay, all right, Jerome, Mike, to you. Very, very intriguing.
All right. So the chest X-ray that was performed, before they even called me for admission was negative for any focal consolidation. The cardiac silhouette was actually normal size. There was no effusions. Trachea was midline. There was nothing else that was acutely abnormal. Blood cultures were collected. Urinalysis, urine cultures were collected. Antibiotics were ultimately deferred because he was so hemodynamically stable, but clearly inflamed. Extended viral panel was negative. He was making some sputum that was pretty much new since the onset of his symptoms, maybe 2 to 3 weeks ago. So we did send off a sputum culture. But I will say the viral panel, his HIV antibodies were negative, Hep C antibodies negative, EBV, syphilis, CMV, all those were negative. Thyroid thyroid tests were negative. Iron studies showed a TSAT of 14%. Reticulocyte index was low at 1%. And we'll say an SPEP, UPEP, antibody levels, light chain ratio, all those things were negative. Well, obviously I sent those off whenever I admitted him, but they came back negative. I will go ahead and say this as well. So we got a CT chest with contrast. There was no PE. There was just some mild interstitial findings, but there was no abscess. There was no effusions. It's pretty much negative. And I'll stop there.
Very interesting. So Minahil, you unfortunately, but in my opinion, fortunately, signed up for a Jerome case, which means we're going to have to struggle very hard to get to the diagnosis. Maybe for everybody else listening, I'm really curious, do you mind kind of summarizing the case so far? What is your mental summary of the case?
Okay, so
I can't tell if you're frozen, Minahil. Can you hear us?
yeah,
Yeah, go ahead.
I'm
Yeah, what's
audible.
your...
Okay.
Yeah, you're audible now. Yeah, go for it. What is your summary of this case so far?
Okay, so like the patient come from the cardiology clinic walking and said that he have a chest discomfort and dyspnea, also have a fever, which like get better on its own. When we do the examination, we just find out diminished breath sound. He have a history of the cardiac issue, so we did the EKG that came out back unremarkable. Then we do like some blood tests that shows like W cells elevated with neutrophil predominant, and it was in respiratory alkalosis, and then thrombocytosis, and most of his like imaging is negative, his X-ray is negative, CT chest is pretty negative, and like all the viral panel, thyroid, all the like basic all investigation is a negative. So like we pretty rule out the pulmonary causes, and like patient have the severe condition, so I am focusing my shift towards that, like if we can get an echo if there is something going in his heart, that will help us to move forward. And also I want to know like the sputum culture, as you know mentioned, the newly developed yellowish sputum, so I will want to know like what's the CS result. What do you think, Ravi?
Excellent. Yeah, I agree with you. I'm curious, what would be your next step? So you said you would consider getting an echocardiogram. You already asked for blood cultures earlier on. What other tests are you thinking about doing for this patient?
So other than that, I will also consider the imaging of abdomen.
Yeah, good.
If something is happening from there.
Good.
Yeah.
Yeah, my mental summary is very similar to yours, Minahil. I think the main problem here is subacute neutrophilic leukocytosis. Honestly, that would be my summary of this case. This is a patient with subacute neutrophilic leukocytosis. That equals pus under pressure until proven otherwise. And so it becomes a question of trying to find where that pus is. We've looked in the chest, haven't found it. And so there are three remaining possibilities. 1, intra-abdominal. 2, intravascular in the form of endocarditis. And 3, intraspinal. So anything in the abdomen can do this. We've already cited some examples. Bacteremia in a diabetic patient, plus minus endocarditis, or even fungemia in a diabetic patient can do this. And then finally, Minahil, look at his medical history. Cervical discectomy, thoracic surgery. This could easily be a osteoarticular infection of the cervical spine or the thoracic spine. So I think it's very, very important to get blood cultures in this patient. And if his CT abdomen pelvis does not show a clear answer, we really need to pursue MRI quickly. And we might in retrospect say, maybe his chest hurts because his spinal nerves are compressed by an infection in his thoracic canal, causing him to feel this way. So this case is a very serious case. You need to get to the bottom of it very quickly. And the question is, where is the pus? Is it in the belly? Is it in the blood? Or is it in the spine? Of course, there are many possibilities of image negative neutrophilic leukocytosis, but we have many tests to obtain before we call it that. So I'll hand the mic to Jerome to tell us more about this intriguing case.
All righty. So I will say that this is now, we'll progress to day 2 of his admission. The team was concerned for pericarditis, so they repeated the EKG. Still unremarkable EKG, no T-wave inversions. Troponins were, again, flat. They got a limited echo to assess for like a low-grade effusion or any inflammation in the pericardium, and that was negative. EF was normal, valve study was fine, ejection fraction was normal as well. No chamber enlargement either. There was a contrasted CT abdomen pelvis that was obtained. No evidence of any abscess, no evidence of any colitis. All of the organs were essentially, I mean, there was like some chronic changes, but nothing acute that would explain this presentation. And yeah, I'll stop right there. In the next aliquot, we'll have the diagnosis.
Jerome, can I just ask one clarifying question? Because to help us ask, did the neutrophilia and thrombocytosis, did they persist or did they vanish?
They persisted, and
Okay.
the team just started antibiotics empirically.
Sure. Yeah.
Because, you know, I think his white count peaked at 30.
Ooh.
Yeah, it went up to 30. So they just gave him antibiotics because we couldn't figure out what was going on. And I'll let you digest that information, and then I'll resolve the case in the next aliquot.
All right, Minahil. Now we get to digest, but since we have a little bit of time, I would love for you and the rest of us to have the benefits of actually having some breakout rooms to digest the case. If you haven't done breakout rooms with us before, we'll just have you all in a small group of people. You can share your thoughts with each other, and we'll come back in a few minutes, okay? If you cannot join, don't worry about it. Just hang out here with us. All right, see you all soon. Back. So, Minahil, you were spending some time with some very smart people. What are your thoughts?
Yeah, so I was like, got a very nice group to discuss. So like our main focus was like infection hiding somewhere in the body. It may be
Yes.
like bone, endovascular, and like want to know like any dental procedure he recently undergone. And like Mark mentioned that we like Francis Vigilecco will be much more benefit in this case if we want to rule out endocarditis instead of just a simple one. And then also considering the spine imaging, because like if the infection is a whole spine imaging, but especially concerned about thoracic. And then like want to know about blood culture, sputum culture, what about his like TB findings. And also we discussed like it can be, we point a little, but like patient have a family history of the cancer. So cancer can also be a possibility. And autoimmune disease can also be one of the possibility of the
Excellent.
condition.
Excellent. Yeah, I'm right there with you. I think we can use this case as an opportunity to emphasize, like, essentially we're on the hunt for where an infection is. And everything that we've talked about, Minahil, so far doesn't use any of the patient's specific history. So in general, if you have a neutrophilic leukocytosis that's subacute, you should image the chest and the abdomen. And if you don't find anything, wait for the blood cultures and image the spine. That's the general protocol. And I think we have to use that protocol on this person to wait for the blood cultures and consider imaging the spine. But we have to also use the patient's unique history. And the patient's unique history also includes two other potential sources. The penile prosthesis, which we have probably seen on exam and caught on CT. So that's a little bit less likely. And finally, the history of the fact that the patient had a transsphenoidal resection of the pituitary. And to wonder, hey, does he have an infectious process or another process in his pituitary? Only after we find no pus in his spine, in his blood, or his pituitary can we consider an autoimmune disease or cancer. I think cancer would have showed up on imaging, so autoimmune disease is probably the only reasonable category. And I think the only life-threatening autoimmune disease to think about early on is giant cell arteritis. So for me, I'd be deciding whether to wait for the blood cultures or to get an MRI. And I think based on this patient's medical history, would probably pursue an MRI on the sooner end. Deciding whether to follow the pituitary or the spine, you might have to, in the end up getting both, though you may start with one or the other. But let's learn from Jerome about how he unraveled, I just learned from him that he was involved in the admission, but how the case was unraveled.
All right. This was a great discussion, and just reading through the chat, everyone's differential is just so much more exhausted than mine was at the time. But it turns out the diagnosis is a little bit more simple. The blood cultures were negative. We only had the chance to send off an ANA and just get complement levels, and those were both normal. Then the patient told at our institution they do a lot of bedside rounding, and the patient spoke to the attending and said, "Hey, can I speak to you in private?" And so the whole team stepped out, and the patient showed the attending. 1 sec. All right. Can everyone see my screen? Oh, go back. Can everyone see my screen? Okay. So this was on hospital day 4. The patient was essentially followed outside in a wound care clinic, and he had this necrotic toe that essentially he didn't want to share with his family or share with any of the healthcare providers because he was essentially embarrassed. And so he asked to speak to the attending in private, and he pulled off his sock, and a piece of his toe actually came off with the sock, which was very interesting. So immediately, we called infectious disease, we called surgery, and he got his right great toe removed the next day. His intraoperative and postoperative course was essentially uncomplicated. After he had the procedure around hospital day 7, he had a cardiac arrest. ROSC was achieved, and he spent 2 days in the ICU. We never really figured out exactly why this patient had cardiac arrest. But ultimately, that is the resolution of the case. And I can share some brief reflections now, or we can just kind of reflect. I'll let Rabih and Minahil reflect, or I can go to my teaching points.
Please, yeah, I would love to hear your reflections and then hear Minahil's as well.
Okay. All right. So for me, this was early on in my second year. So what was very helpful for me was, one, I didn't think to do a foot exam. That was, something that just was not, present because he was fevering, he was short of breath, he had chest pain, and the background history that was very complicated. He had this thoracic surgery, he had this pituitary adenoma, he had this cabbage history, came from cardiology clinic. So those things were, pretty appropriate, I think, for a first pass, but that was something that just didn't really, pique my interest initially. So as I followed his admission, I was the admitting, cross-covering a night resident and kind of following things throughout the day. Like, he's inflamed, we just got to figure out exactly why. And so we kind of went down a similar decision tree. Is this the pericarditis? Like, is this an autoimmune disease? Is this some sort of myositis or something, some connective tissue disease or something? But ultimately, it turned out he just had a necrotic toe, and he had, diabetic neuropathy, and he was just withholding this information for us. So for me, the biggest thing was just the humility that came from my, attending and some of the other seniors that was there. And, you know, they kind of, it was like, whoa, this was pretty much a critical miss. This was something that, you know, we didn't really think to do. And, you know, on even reflecting on the case, it was just like all the things that we considered were obviously the life-threatening things. But it was just something that anyone who has type 2 diabetes, coming in hyperglycemic, sick, you need to do a foot exam, especially if they're inflamed. And so even in a lot of the discussions, like throughout the chat and everything, I was just like, whoa, no one else kind of caught it. So it kind of made me feel reassured. But ultimately, that's just one of the things you can't, you know, always give consideration to base rate. And that was the biggest reflection point for this case. So even patients who are coming in, you know, with sepsis syndrome, you know, they're hypertensive, febrile, and they have a history of diabetes, I always look at the feet. I've done more foot exams since this case, just simply because you know, how this turned out. But also do not underestimate the anxiety that patients can have with bedside rounding. And so, you know, having all of your medical information just kind of on Front Street, even though we're medical professionals, is something that we should still give a healthy degree of respect to patients, because sometimes they will share with you some very critical management changing information if they, one, feel comfortable, and one, you know, feel like this is a safe space for them to be open about it. And
I can't thank you enough. This is one of my favorite cases of VMR. You shared earlier, I think it was when we weren't recording, that it's one of your favorite cases of, or the favorite case of residency, and I totally get why. You were teaching us the most important lesson, I think, which is that the physician-patient relationship is the bedrock of what we do. And the healthier, more open, more transparent, and more honest the physician-patient relationship, the better for everybody involved. And when that's compromised, for whatever reason, social, personal, shame, guilt, medical care is compromised. And I think that I had imagined that if this patient were seeing their long-standing primary care doctor of many decades, this issue would have never played out the way it does. But it's teaching us a humble lesson that in the way that modern medicine is practiced, that idyllic form rarely exists, at least in many parts of the US. And so we have to really, really make sure that we hear and address all our patients' concerns, and that's really, really difficult. I've been in very similar situations, Jerome. I'm very, very humbled. I absolutely love this case. We found our pus under pressure, but yeah, it took longer than we might aim for next time. Minahil, what are your thoughts or reflections?
Yeah, this was a great lesson for me before starting my intern year. The relationship between a doctor and the patient. I also presenting my first case on the same like lines where there was a mistake in history taking, and later we found out. Mark remembered that that was a city process. So I always say that like take your time with your patient, spend the time, get to know with the patient, and like do all the physical examination. With whatever complaint the patient comes, you have to take all your headings for the physical examination.
100%. Very, very well said. Jerome, this was such a treat, and I had a pleasure to co-discuss with you. Eugene, you kept up with a very tricky case, a lot of scribing. Julia, I owe you an apology. Unfortunately, I have to leave now to make it on time for work. So I will make you, Julia, the host for your teaching points, and excited to check them out later. See you all later.
I'll keep it brief because I feel your reflections on the case were so intriguing that I don't want to add a lot, but just by thanking you to bring this beautiful case. And I feel from the beginning it was starting kind of slow and gained so much momentum. I mean, we had an 80-year-old man just presenting slowly with a subacute syndrome of dyspnea and chest discomfort. And I felt what I learned is that not on the one hand, really rule out the life-threatening causes, but don't get distracted that much and really do your thorough physical exam. So thinking about excluding our 4+2+2 mnemonic, but still like seeing the patient as a whole, I think that is the lesson learned today. And the other one, or big source of distraction today, was also what kind of signs and symptoms were due to maybe a chronic underlying disease, or rather being a picture of the acute presenting illness. And I think in this case, the diabetes made him vulnerable to the foot infection. Where we found some information on the lab and distinguishing how that can help us to find our pus under pressure. I think that was the magic clue. Lastly, I think just to make pass under pressure more clearly. I feel I love the emphasis on our subacute picture that was shown by the thrombocytosis and also like the symptoms that our patient had, but also the marked neutrophilic leukocytosis. So we really have to find the origin and use our like relationship to the patient to find it, and that's probably the most crucial takeaway for today. So I guess I'm still intrigued, Jerome. Thank you so much for bringing this case, and I hope to see everybody tomorrow.
All right. Thanks for coming, everybody. I have another fun case for us tomorrow too. I'll see you all.
I saw you're presenting. Bye bye.